welcome this morning to our actually the 2021 Teaching Award presentations. And it's absolutely fantastic to see such a big crowd out for what we consider to be a very important event. If you think about it, and if you think about a department like medicine where we hold four real distinct missions, we have a clinical care mission, a research mission, a community mission, and a teaching mission. That one might think that teaching is the foundation of all of the missions because we teach across all of those settings. We teach in the clinical setting. Many of you teach in the classroom. We teach during the research programs that we're running in the department. And increasingly, we're creating partnerships where teaching and education is an important part of our community activities. And so it's really an important part of the department's overall mission to acknowledge those who are considered by their peers to be outstanding educators and outstanding teachers. So today, what we're going to do is present the Teaching Awards. I will read all the names. As I read your name, if you could please come up to the front, Abraham will provide you with the certificate. And then if you could stay so that we can take a picture that we can use in our departmental communication activities, that would be terrific. For the audience, and what a great thing to say, for the audience who's actually here, for the audience, could you hold your applause until we've acknowledged everybody so that we don't miss any names and come to the front. Thank you to all the Department of Medicine staff who have put all of this together. When we're finished with the taking pictures, what we'll do is have Kelly Skeff, and it was remiss of me at the beginning, I should acknowledge that the annual grand rounds that acknowledges our teaching award winners is now named in honor of Dr. Skeff. So Kelly, thank you for being here today. I always figure that everything to do with teaching gets credited to Kelly, but I should have said that. So let me start to read out the names here. And they go by division. From Biomedical Informatics Research, Jonathan Chen. From Blood and Marrow Transplantation and Cellular Therapy, Matthew Frank. From Cardiovascular Medicine, English Nitgig. Now, endocrine is a tough one. They couldn't decide. So we have three outstanding teachers, Marilyn Tan, Rick Kramer, and Deborah Solmeyer. From Hematology, Gabriel Manis. From Hospital Medicine, Mingao Go. From Immunology and Rheumatology, also a toss-up, Janice Lynn and Rob Fairchild. From GI and Hepatology, Paul Kuo. From Infectious Disease and Geographic Medicine, Jenny Aronson. From Nephrology, Pedram Futai. From Oncology, a former Stanford chief resident, Tyler Johnson. From Primary Care and Population Health, also quite a lineup here, Dr. Chang, Andrew Sheckman, Sylvia T, and Kim Chiang. From Pulmonary Allergy and Critical Care Medicine, Brian Shaler. And from the Stanford Prevention Research Center, Tia Rich. If we could have a round of applause for all of them. Now I have a couple more acknowledgments, including what we consider to be two of the bigger awards in the Department of Medicine. A number of years ago, we instituted the Master Teaching Award and the Master Clinician Award. We were not able to give the prizes out for 2018 and 2019 in a live audience because of the pandemic. And so I want to acknowledge that in 2018, Marina Bassina, and in 2019, Tim Meyer were acknowledged as master teachers. So if I could have a round of applause for them both. And this year, it's really an honor to acknowledge Wen Kai Weng as the Master Teaching Award recipient for 2021. So those of you who don't know Wen Kai, he's a member of the BMT division, so congratulations. And finally, we'd like to acknowledge the Master Clinician Award. It was awarded for the first time in 2019 to Randy Vagelos. And today, I'm really pleased to announce Linda Nguyen as the winner of Master Clinician Award. For GI and hepatology. And for those of you who have had the privilege of sending your patients to see Dr. Nguyen, I think she calls herself the MacGyver of GI medicine. So I think it's an apt description. So congratulations to all the Teaching Award winners and the Master Clinician Award winners.
First, Bob, thank you so much for that honor. My God, I'm so impressed. Thank you so much. So I'm humbled. Well, it is an extreme treat for me to introduce you to Dr. Holly Humphrey. 14 years as a director of the internal medicine residency program at the University of Chicago, 15 years as a Gerard Professor of Medicine and Dean for Medical Education at the University of Chicago, and now the esteemed national leader of the Macy Foundation, a foundation committed to medical education like no other foundation. But where's Holly coming from? The University of Chicago. And she spent her entire career at the University of Chicago. And it's appropriate today at the Teaching Awards to recognize the fact that the field of education was essentially established at the University of Chicago. John Dewey, considered the father of education, comes from the University of Chicago. Ralph Tyler, the innovator of curriculum design, comes from the University of Chicago Education School. And all of you deal with the effects of Benjamin Bloom, the inventor with many people of Bloom's taxonomy. And all of you, as you define the goals and objectives of your CME courses, are really working with the work of Benjamin Bloom from the Education School at the University of Chicago. But before I learned about the pioneers from the Chicago School of Education, as a new program director in internal medicine, I was exposed to luminaries at the University of Chicago in the School of Medicine. And two of those luminaries stand out: Arthur Rubenstein, who was the chair, and Holly Humphrey, who became the program director the same year that I did. And we have become close colleagues and friends since that time. And as a wonderful and powerful duo, as Dr. Humphrey and Dr. Rubenstein, chair of medicine, established what it meant to be a role model in the field of medicine. They made several characteristics stand out. They not only exhibited the high intellect and the depth of knowledge and the spirit of inquiry of academic medicine, but they also exhibited the spirit of humility, the spirit of professionalism, and the deep spirit of caring for patients and caring for their colleagues and caring for our profession. And it's in the beauty of these characteristics that made me always want to recruit as a program director anybody who had gotten anywhere close to Holly Humphrey, because she rubbed these characteristics off onto them. And it's been such a treat to have some of those folks here. And last night at dinner, we had several of them talk about the incredible impacts that she had on them decades ago. So in thinking about a speaker for the Teaching Awards, I was pleased to ask Dr. Humphrey with the hopes that, like she did with Chicago students and Chicago residents and Chicago faculty, that she would be able in a very brief time to successfully have some of her wonderful characteristics rub off on us. So it's in that spirit that I ask you to help me in welcoming Dr. Holly Humphrey to the stage.
Wow. I think, can you hear me? Okay. That introduction tells me that I should perhaps stop before I even get started. That was incredibly kind and generous, and I'm being told to use a different microphone. Okay, boy, what a treat, what a real honor for me to be on this campus, a campus that I have not had the pleasure of visiting for many, many years. But yesterday when I arrived, shortly after all that rain fell, I was taken aback by the beauty of this campus. And it was a powerful reminder of the asset that you have and enjoy every day, whether you're here in person or working remotely, an asset that this university looks to have stewarded especially carefully. And so if you haven't thought recently about the beauty of this campus on which you work, I'm happy to be here today to remind you of that, because it truly is extraordinary. It's also extraordinary that you as a department have set aside special time to recognize your teachers. And like Dr. Kelly Skeff, I am just tickled that you have named this event in his honor. His impact, as all of you know, goes far beyond this particular campus, far beyond our nation, and extends all around the world. So we are going to cover a lot of territory here this morning. I'm going to move quickly because I do want to save time for us to have a conversation. I'd like to begin by letting you know I do not have any conflicts to disclose, but I'd like to say right up front that in the spirit of serving as the president of the Macy Foundation, I'd like you to know what our mission is. And it was already referred to by Dr. Skeff as improving the education of future health professionals for a healthier public. And we aim to do that by executing on three major priority areas: promoting diversity, equity, and belonging, increasing collaboration among future health professionals, and helping future health professionals navigate the ethical dilemmas. All three of these priorities in our clinical learning environment, so that we can have healthier people and ultimately healthier communities. That also aligns with those four mission areas that you just heard your chair refer to. Now, I would like to say that when we cover this case presentation that I will present this morning, I do not want this to reflect in any way on those who were my outstanding teachers, role models, and mentors at the University of Chicago. Consider this my own attempt to try to cover a very broad series of issues in a way that is relatable, the clinical case presentation. So it will be familiar to you with a chief complaint, a history of the present illness. I will go so far as to share a few exam findings, make a tentative diagnosis, and then outline a treatment plan. And it's that last point that I hope we can spend some considerable time on. So the chief complaint today is that we find ourselves with an ancient profession complaining of shortness of breath, dizziness, and insignificant GI distress. So let's learn more. This is a long history, and I don't have time to go through it in detail, but let's begin by what's happening in society. And what you see depicted on this slide is the fact that the National Opinion Research Center does a general society survey every year. And in that general society survey, they are looking for social trends among the American public. And what you see is a single question on a survey that has multiple questions. And this question is related to the percent of Americans who have a great deal of confidence in the scientific community. And in the faint gray line in the middle, you see that over time, the confidence of Americans in our scientific community has been largely stable at about half of the country have confidence. But what is different is between 2018 and 2021, which is the last data point on this graph, there has been a widening, a polarization, and that polarization has fallen along party lines, so that those who identify as Democrats are increasingly likely to have more confidence in the scientific community, and those identifying as Republicans, less confidence at 34%. So I think it's not news to any of us that we are living, working, and engaging in our profession in a polarized country. It's also the case that there is an erosion of trust that is being looked at by many different organizations. And this particular question was about how the pandemic has influenced trust. The public represents a total of about 2,000 Americans who were surveyed. Physicians totaled 600 physicians who were surveyed, and you can see that trust remained about the same, both for physicians and the American public. Among physicians, there was an increase in trust compared with members of the public as a direct result of the pandemic. Before the pandemic ever happened, Tedeschi and colleagues did a survey that involved more than 2,000 Americans and several physicians. And among the data points that were collected in this survey data, you can see that 59% of physicians were reporting offensive remarks about one of their personal characteristics, whether it was gender, age, ethnicity, etc. 47% reported patients actually requested a different doctor. 14% reported patient complaints that were submitted in writing about their performance as a physician. 12% reported offensive comments that were made by patients about the physician's weight. And not surprisingly, African American, Asian American, and women physicians were most at risk from this kind of offensive behavior from patients. During the pandemic, the World Health Organization made an official statement that one of the issues plaguing our global response to the pandemic was an infodemic with too much information, including false or misleading information that was taking place in both digital and physical environments. And more recently, the Surgeon General of the United States issued a similar statement about the dangers and the profound health consequences of misinformation. More recently, many of our public health colleagues in particular have commented on the assault by the Supreme Court on public health. And this extends beyond issues related to reproductive rights for women and the healthcare providers providing care, but it includes issues related to climate change, and we are about to see two really important cases related to students for fair admissions against Harvard University and against the University of North Carolina. So there's a lot happening in our society. What is happening in our profession? Let me take a big step back to the beginnings of medical education in this country. And at the time of the Flexner Report, there was a real reorientation to a student-centered approach to learning and training as a result of the Flexner Report. Several decades later, that student-centered approach morphed into a faculty-centered approach, and that really coincided with the rise in research funding that was coming from many different sources, but most notably from the NIH. And then in the more recent decades, that faculty-centered approach has evolved to a patient-centered approach, and this was largely originally driven by managed care and the health insurance industry. So with that big picture, what are some of the more specifics in our medical education enterprise that we can consider and take a look at? One is that we have historically had a big chasm between undergraduate medical education and graduate medical education, such that our medical schools often do not talk with our hospitals and health systems where our residents are working and are employed. But think beyond the Stanford universities and from the University of Chicago to the vast majority of where graduate medical education is taking place. And in those cases, we have physicians who are graduates of osteopathic medical schools and of international medical schools. And in those cases, the chasm is perhaps even wider between undergraduate and graduate medical education. 2 weeks ago, there was a meeting on the transition to residency, and there were 5 key themes at that meeting, which you see on this slide. Those themes were resilience and well-being, the financial literacy of managing the enormous amounts of debt from medical school, inclusivity in our clinical learning environments, the curricula being covered on racism and the social determinants of health, and then the educational handoffs, both within our training programs and our medical schools and between the medical schools and residency. This is a graphic depiction of the clinical learning environment where a lot of the challenges for our profession take place. This was developed by Larry Gruppen and colleagues at the University of Michigan. There are 4 major parts to this clinical learning environment. I don't have time to go into these in detail, but you see as depicted here that the personal characteristics that we bring to the profession together with the social organization of our profession and of our individual teams as we work together, the organizational policies, procedures, the climate. We create the climate together with a whole number of system forces. And then the physical, and very recently, we've all had a lot of experience with the virtual spaces in these environments. At the same time that we outline some of these challenges, we have seen and been witness to amazing scientific discoveries from precision medicine. And I know you have a major set of programming in this area. The COVID-19 vaccine development itself, which actually took place over many years, and it seemed to us as if it was warp speed, but that scientific inquiry had been going on, of course, for many, many years. Robotic surgery, gene editing, a whole host of truly amazing scientific discoveries. We also know all too well the pressure on faculty time, and that pressure has intensified in a way that we all know is not sustainable, and I think was brought to a real head during the pandemic. I think many of you are aware of this paper recently published by Kelly Skeff on the ways in which this electronic medical record is producing a whole set of challenges for physicians everywhere. And I know that Kelly's eager to continue this work, and I'll have more to say about the electronic health record momentarily. This profession, if we take a look at it, we have been very slow to adapt over the history of this ancient profession. Think about how have we done in addressing the implicit harmful bias that's part of the profession? How have we done in really identifying and tackling discrimination within our profession? What about presenteeism among resident physicians? This is actually data from a study in 2010 when 600 residents were surveyed and asked whether they had occasions when they came to work sick, and 58% said that yes, they had come to work sick at least once, and 31% of those residents said that they came to work sick more than once. Now, during the pandemic, we saw an abrupt change in what had historically been presenteeism, because there were all kinds of policies and procedures that did not allow us to come to work while we were sick. But the now unpublished data is that it has not taken a very long period of time, both in formal and informal ways, where we are right back to the presenteeism that took place before the pandemic, where people and our residents in particular are coming to work sick. This topic of the silencing of our health professionals and physicians in particular has come up over and over again. And here is a quote that the physicians report: a climate of silence in which they would not share problems due to fear of retribution or lack of confidence that the problems would be addressed. The Macy Foundation sponsored a conference a year ago on the impact of COVID-19 on our medical and nursing education. And to a person, the students, the residents, the program directors, and the faculty who participated in that conference spoke about this issue as one of the most challenging issues that they faced during the pandemic. And then it's all too familiar to all of us that as we have tried to solve some problems in the profession related to the grueling demands on time, by implementing the duty hours, we have created work compression that many people believe has actually harmed not only the safety of our physicians and but the quality of care that we're delivering to our patients. Okay, so we've considered what's happening in society, what's happening in the profession, what's happening to our physicians themselves. So to answer that question, let's think about who is it who's becoming physicians. And what you see here is data from the Association of American Medical Colleges that shows us the quintiles of family income plotted here across the screen. And from 1988 to 2017, the top 2 household income quintiles in the United States contributed 3/4 of matriculants to our medical schools. You see from 2007 to 2017, 1/4 to 1/3 of those matriculants came from households where the parental income was in the top 5% of all U.S. households. That's represented in the hashed parts on the far right side of this screen. So what I'd like to ask you to think with me about is, in the gold bars are the individuals who come to our medical schools from families with family incomes in the $1,000 to less than $75,000 range. And I'm wondering how those students who become our residents, who become our faculty, feel about being in this profession. What kind of a safety net do they have? There's also some really good news about who's becoming physicians. And in 2021, so this is the most recent class to have matriculated in medical school, we saw a 21% increase in Black or African American students enrolling, an 8% increase in Asian students, a 7% increase in Hispanic and Latino students. When they come to our medical schools, by and large, how is it that we as faculty assess our students, their performance and progress? Have we lost our learners' trust by over-relying on standardized examinations for selection? Are there disparities in our clinical performance evaluations? We know that there are disparities in selection for honor society memberships, and we know, based on data that's been shared by the Accreditation Council for Graduate Medical Education, there are racial differences in the dismissal rate among our residents from our residency programs. We also know, based on a significant amount of data that's being published, that we have gender disparities in medicine that involve everything from promotion, with an important paper by Richter and colleagues published in 2020 in the New England Journal of Medicine. This is data published in Health Affairs December 2021 about the difference in income stratified here by primary care fields, non-surgical fields, and surgical fields, showing that over the course of a 40-year career, women physicians are earning an estimated $2 million less than male physicians over that same time period. We also know that for a long time, we have had equity in terms of numbers of medical students who are enrolling in our medical schools by gender. But look what happens to the pipeline over time. And on the far right of the screen, look at the very small dots for the percent of women, department chairs, and deans. And again, this is a diagrammatic representation of data from 2018 and 2019. But if you look back over the course of time, this is an issue that has been present now for decades. Okay, so that is a very big, broad survey of what's happening in society, what's happening in our profession, what's happening in our physicians. Let's think about our exam findings and results. Clearly, this is a profession with an elevated heart rate, respiratory rate, a elevated temperature, and there are definite signs of systemic inflammation. It's certainly the case that among the findings that we have, and this from your own faculty, Tate Shanafelt and colleagues, showing us that from 2020 to 2021, the percent of physicians reporting one symptom of burnout increased dramatically. The percent of physicians reporting satisfaction with their work-life balance decreased also dramatically. Now, the pandemic obviously had a significant impact here, but this, I think, is as significant a crisis as any that we have faced as a profession. So, what is the diagnosis? I'm going to postulate that not only are we a profession in distress, but we have multiple organ dysfunction with systemic inflammatory response syndrome. I'm not going to go through the details of which part of the SIRS criteria we meet, but I would like to point out that SIRS, of course, can occur from many different etiologic entities, but I'm going to postulate that this has been caused primarily by repeated episodes of trauma. Now, it's easy to stand up and outline our problems. And I could have obviously talked about this for much, much longer. But what I'd really like to invite you to help think about is, what are we going to do about all this? What is the treatment for this ancient profession in such distress? And I'm going to approach the treatment in the same way that I outlined the problem. And that is to consider, are there things that we can do to address these issues from a societal standpoint, from a profession standpoint, and on behalf of our physicians? From the standpoint of society, I'm going to say that there are at least 4 things that we could, in fact, do. And that is outlined here by promoting trust, the codes of conduct, combating misinformation, and promoting advocacy. The American Board of Internal Medicine is working very specifically in a focused way on rebuilding trust with our profession and with society. They are engaged with a variety of different partners on this effort, including the Edelman Trust Barometer, and they have a lot of very interesting and I think helpful information on their website that outline some of the ways that they are working on behalf of the profession to move this forward. Obviously, a lot of this has to do with communication and building trust across the entire health ecosystem, owning the employer role in our health outcomes, and preparing for the next public health crisis. Obviously, there are many partners who we must engage in this process. And the one piece of really important news for faculty who are teaching and seeing patients is the highest levels of trust, as measured by the Edelman Trust Barometer, were between patients and their individual personal physician. And that, too, has been steady and stable over decades, even at the present day. Now, I know that you and many institutions have codes of conduct for patients, for families, for visitors, for physicians and other health professionals. I'm sad that we have a situation where the trust is so low that these codes are important, but it turns out that these codes are important because they set expectations for what is acceptable and what is unacceptable. And for too long, we have often sat silent when we have observed right in front of our eyes things that we know are wrong taking place in our clinical learning environments. And so to the extent that the code of conducts help us outline and speak out loud the transgressions when we see them, that in fact should improve the climate for the profession and for the public. The third point is to combat medical misinformation. And there's some real money behind this particular goal, and that is that earlier this year, the Association of American Medical Colleges partnered with the CDC, and together those two entities have a program for kickstarting strategies for addressing medical misinformation. And presently, they are funding program projects at 5 medical schools to address medical misinformation and to engage the students, residents, and faculty in those 5 institutions to engage with patients and others to combat medical misinformation. That includes incorporating this into the curricula and actively engaging in teaching and learning related to medical misinformation. And hopefully those 5 projects will be able to be disseminated to schools and programs across the country. It's also the case that part of this treatment involves more formal teaching related to advocacy. Our students come to us with hearts full and brimming with an interest in being advocates. And a recent survey showed that 77% of medical schools in this country do have at least one course on advocacy for their students. However, the vast majority of those courses are elective courses and not part of the required curriculum. So those are just a few parts of the treatment plan that have a direct impact on society. Let's turn to the treatment plan for our profession itself. And I'm going to suggest that we consider reorienting the focus of medical education, that we build a true and real continuum, that we promote exemplary learning environments, that we really do focus on what began as the triple aim and is now being postulated as a quintuple aim, and that we really do embrace the change that we have all been a part of. So I already reviewed the history, and what I'm suggesting is that given the challenges that we're facing in our society, should we consider reorienting the foundation for our curriculum into a socio-culturally centered curriculum? Because our teaching and our science and our patient care taking place isolated outside of the context in which our patients are living, forming their opinions, and coming to seek our care will in fact potentially be fraught and continue to create stresses both for the patients and for the physicians delivering that care. So a sociocultural orientation could help provide a broader perspective and draw on the expertise of our colleagues in the social sciences who've studied these social trends and interventions for decades and decades. And while we have been masters at biological science and physical science, we have not adequately incorporated the expertise of our social scientists. To build a true continuum of medical education is in fact not asking our learners to leap from medical school into our residency programs, but to create a bridge with supports that make that a true continuum so that the same kinds of assessments are used, so that the language that we use on physician progression and development is language of a growth mindset and language that promotes the formative development of physicians rather than the summative judgment that has historically been part of the profession. These are the characteristics of an ideal learning environment that we might aspire to, where people's health is the priority, all people within that environment, where the climate is equitable and diverse and creates a sense of belonging for all who work and receive care in those environments, where learners have real responsibility and relevant, meaningful experience, where there's psychological safety for all, and where collaboration characterizes the clinical care team. I mentioned the quintuple aim. You're familiar with the quadruple aim, and I'm suggesting that we do what has recently been written about, and that is embrace the quintuple aim, where advancing health equity is an integral and equal part of what we're trying to do in a very broad way across the profession. I mentioned the EHR. This is well known to everyone practicing clinical medicine today, that our billing and documentation document has taken over the physician-patient relationship in a way that has been taking place now for way too many years, has burned out the physicians, and has caused our attention to be focused not on the patient in front of us or on the brilliant scientific advances, but on the dutiful recording of the boxes that we check in order to generate the bill that pays for the beautiful assets that I referred to earlier. However, a recent report from the National Academy of Medicine outlines several very specific steps that we need to take and drive as a profession in order to right this wrong. And that report is available on the website of the National Academy of Medicine. I won't go through the details now, but I hope that as a profession, we will embrace this change and make it a reality, not only for the present, but for the future. So I mentioned embracing change. The convening that the Macy Foundation did a year ago about the impact of COVID-19 on medical and nursing education had a number of recommendations. One of the papers that we commissioned for that conference was authored by medical students and nursing students, and the overwhelming message that the students gave to us was they saw remarkable innovation, ingenuity, and nimbleness that took place at the beginning of the pandemic, unlike anything they had seen in the course of their medical education. And they challenged us to go forward with that same kind of ingenuity and nimbleness in how we organize the curriculum, in how we organize this profession. And they pointed out to us that they have watched for years and years and years and listened to us say that change takes time. And they wanted us to know that now they had seen it doesn't take quite as long as we think it might. Let's turn to that final part of the treatment plan, and that is, what will we do for our physicians themselves? I mentioned these amazing statistics for the most recent class matriculating to our nation's medical schools last fall. What I'm inviting us to not only consider, but to deeply engage with is that we now need to work on the holistic retention strategies for everyone who is a part of this physician practice. To that end, the Macy Foundation later this month is convening a conference on the topic of ensuring fairness in medical education assessment, with the vision of trying to credibly work toward diversity, equity, and inclusion and belonging in our classrooms and clinical learning environments by adapting evidence-based programs of assessment that neutralize the harmful effects of bias and ensure that all learners are evaluated fairly. So there is more to come. Now, I also mentioned that by and large, those who are attending medical school in this country today come from the wealthiest quintiles of American families. But I invited us to think about those who do not come from those quintiles and remind us all that we have in our residency programs and in our medical schools individuals who are accumulating huge amounts of debt, who may not have any safety net at all from family or community, who may be exceedingly isolated, far beyond our ability to recognize it, that on a daily basis, they may well face systemic racism. They represent a very important pipeline into our future faculty, into our future profession. And we will only address the social determinants of resident education if we're willing to tackle the very real burdens that require resources. There are so many examples of this, and I'm going to share only one example, and that is that in July of 2021, the American Board of Medical Specialties announced a progressive leave policy. This is an ancient profession. What took us so long to introduce a formal policy for parental caregiver medical leave for those training within our programs? So that brings me to where we began the day, and that is to recognize and reward teachers. So the most important symptomatology of this profession that is short of breath, dizzy, and with significant GI distress is to focus on the physicians within this profession. The physicians who, many of whom you honored today for their outstanding teaching. And it's those physicians who are your most outstanding teachers, and the many clinicians who are taking care of patients in your beautiful facilities, and the scientists who are at work across the street in the laboratories, who in fact are your greatest assets, and in fact are the greatest assets in our country to really heal this profession. And when I personally think about that, I am reminded of the passion that I have developed for my own career. And that passion developed long, long ago, even without me knowing it. But when I reflect back on it, my passion developed at the intersection of the vulnerability of patients and the vulnerability of our most junior trainees. And as we think about really healing the profession, I think the centerpiece is to center our work on the most vulnerable, who historically have been our patients and the most junior trainees. And I think today it includes our faculty and our entire profession. And when we do that, it's worth taking the very long view, because we can see who we recognized here today. And I know there are people participating in this session by Zoom and participating here in this room who have been directly impacted by one or more of the people who were honored here earlier today. But what we don't see in this room are all the people who a decade from now or a generation from now will have their own passion and their own work, whether that's in science, clinical care, teaching, or some combination of all of that, that was directly related back to one or more of the people who you honored here today, because the ripple effect is significant, it's enduring, it's longstanding. I'm going to stop right there and would be very happy to take any questions that you might have about the ancient profession in distress that I believe will be most powerfully healed by you and I, the people in the profession, willing to take on the very hard work about those things that we can directly control. And I tried to be very true to putting on that list things that we can control, not things that we have to go elsewhere to get solved for us. So let me stop and I'll be happy to take questions.
This mic over to Dr. Skeff, and Dr. Skeff's gonna, we have about 5 minutes for questions. Thank you so much for a wonderful presentation. We can even go over a little bit if you'd like, but I'm gonna give that to you. And
thank you, Holly, for such a wonderful, comprehensive look at the challenging thing we're in. Please, let's start.
Thank you, Dr. Humphrey. David Nicholas. That was a fabulous presentation.
this.
Thank you again, Dr. Humphrey. That was a fabulous presentation. And I thought back to the patient issue, and I wanted to ask a very simple question also. If we're working so hard and we're having such challenges, are we understaffed? Does the data say we're understaffed? Is it possible we just need more?
That's a great question. That's a question the residents used to always ask me. And the data that I reviewed did not look specifically at that question. So my simple answer is I don't know. But I think that a system science and a team science approach would ask that very question. And I think it's one that we need to answer. I also think that in answering that question, we need to be really focused on the team, and that the members of the team are doing the work that is consistent with their training, so that we don't have individuals doing work that is better done by other members of our health professions team.
Dr. Humphrey, thank you again for joining us and for a fabulous presentation. You know, Rob Califf, the FDA commissioner, recently said that one of the leading causes of death in the United States is medical misinformation. And I agree with you that clinicians, we need to be part of that, combating this. What do we do on a university campus where we have faculty like Scott Atlas, who are promoting medical misinformation, but is doing it in the context of academic freedom of speech? And how do we battle that? Our university has not been very good with this. And I'm curious as to how you view the issue.
Yeah, thank you for that question, Dr. Harrington, and for assembling such a wonderful department here. I did think about Scott Atlas as I was preparing to come to Stanford. And of course, I come from a university that holds a few primary tenets very dear, one of which is the First Amendment and the Constitution. And so I come from a campus where that debate has raged on for my entire time and long before I was on the campus. I think that while the freedom of speech rights are obviously important, our profession has ancient and contemporary expectations to be a member of this profession that the public trusts us with. And if we really earn the trust of the public, then we have to manage our colleagues. That's what the self-governance of a profession is all about. And there may be times when the tenets of the profession are in conflict with the basic rights of the Constitution. But in the case of the profession, I think the profession needs to police itself. And I don't think we have done a good job of that during this misinformation campaign. I know that the several certifying boards have moved to remove certification. I know the National Academy of Medicine has removed individuals from the National Academy of Medicine. Those are examples, but our universities have not had that same kind of fortitude. So I think the profession, if we can speak with a single voice, which is a huge if, I mean, that's a first step, I would invite us to answer, are there some core principles that we believe in or not? I would think that there are. And for me, the vulnerability of a patient, whether ill or well, is going to trump, sorry, I used that word. It's going to have precedence over other rules. So I think those are the rules of the profession. Thank you for that question. I did not cover the looming threats to our profession, but I would put that one at the very top of the list. And I think the corporatization of medicine and healthcare in this country, including the ways in which private equity is buying up physician practices, primary care practices, and specialty practices, is the single greatest organizational threat to this profession. And patients and physicians are caught in the middle of the profit sharing of a profession that was not set up to be able to respond to that kind of challenge. And we've seen it happen in American newspapers and journalism, and now it's in the profession. And unless we organize ourselves as a profession to speak with a single voice, this will take us all to our knees.
Let's take the last one because we're out of time. How is the vital aspiration of centering on the vulnerable fitting with the world's only for-profit medical system?
Oh, you're asking such good questions. I think at some point, as a profession and as a society, we have to reconcile with what our fundamental beliefs really are, what our core values really are. And at the end of the day, as we watch our society and our institutional structures imploding all around us, we have to ask ourselves, what is really fundamentally important? And I, for one, am going to stand behind caring for the vulnerable. And I think to sustain ourselves in this profession as we care for the vulnerable, whether that's a patient, a trainee, a colleague, faculty member, there is meaning and beauty that is created that becomes a sustaining force. Now, I know that in some ways that's pie in the sky and that doesn't put groceries on the table. But if we don't stick to our core values and be able to articulate them very clearly to ourselves and to our colleagues, we really will continue unraveling in a way that is going to be extremely hard to put back together.
Thank you so much. I thank you for coming, opening our eyes to so many things, and I hope we can join you in going after these particular issues to help ourselves who now become part of the vulnerable.
Thank you, Kelly. Thank you all very much.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.